Hello everyone, Drew Thompson speaking to you from the Division of Emergency Medicine Point-of-Care Ultrasound program here at Western University. Welcome to this installment in our Practical Point-of-Care Ultrasound series. The goal of this session is to review the scanning techniques and proper archiving for assessment of the abdominal aorta. A subsequent screencast will provide a review of some of the pearls, pitfalls, and clinical applications of this study. And as always, please visit us at WesternSono.ca for all of our updated ultrasound resources. The target of bedside evaluation of the aorta is to determine the presence or absence of an abdominal aortic aneurysm. To do so implies that we can see the full length of the intra-abdominal aorta and make clear determinations of its diameter along the way. In point-of-care assessments, we are most interested in identifying the course of the aorta from its most proximal origin at the diaphragmatic hiatus all the way to its ultimate bifurcation into the iliac arteries. A normal aorta is considered to be less than 3 centimeters in diameter. Anything greater represents aneurysmal change. Of course, if one cannot see or measure the aorta and its maximal diameter throughout its entire course, then the study must be called indeterminate, and other means of evaluating the aorta should be arranged if clinically indicated. As you will recall, there is a common approach that can be applied to scanning in all of the basic applications of point-of-care ultrasound. The anatomic landmarks are reminders of where to place the probe on the patient's body when beginning a study. The sonographic landmark is an identifiable structure on the screen that tells you are in the right location to begin looking for your area of interest. And of course, the area of interest is the target of the study, the area you're looking to evaluate for positive or negative findings. As a simplified reminder, when you begin scanning, in basic applications, the area of interest is always white, and it should be found before any interpretations are made about what you see on screen. When we apply this approach to the bedside aortic study, the anatomic landmark is the xiphoid, the sonographic landmark, the vertebral body and its acoustic shadow, and of course the area of interest is the aorta, but most specifically the white outer echogenic wall of the aorta. As a reminder of the pertinent anatomy, we have placed a familiar axial CT cut through the mid-abdomen beside a similar image generated by point-of-care ultrasound assessment. On the left, we identify the vertebral body at the patient's back, and by convention we know that the patient's right is situated on screen left. It's as though we are looking through the body in cross-section while standing at the patient's feet. Immediately anterior to the vertebral body, we can see a vessel, in this case also laden with some calcification. This is the abdominal aorta. A second vessel is seen in this vicinity and represents the inferior vena cava, the IVC. Turning our attention to the ultrasound image, we will again see that the orientation of this image is in the same plane as the CT scan, and in point-of-care ultrasound lingo, this is a transverse scan of the abdomen. By convention, our probe marker will be shown on screen left and represents the patient's right. Here we can again identify the vertebral body, although in this instance it's characterized by a curvilinear echogenic line and an acoustic shadow immediately in its far field. This is our sonographic landmark for the study. The identification of this landmark tells us we are in the right vicinity to look for our area of interest, and here it is easily identified as a thick-walled structure immediately adjacent to it. This is the abdominal aorta. In a moment, we will add a technique for confirming that we are in fact identifying the right vessel, as at times the distinction between the IVC and the aorta can be a bit unclear. Here is another example of the classic images we will be generating of the aorta. We identify the spine and its acoustic shadow, and immediately adjacent to it, we find the aorta. Although the area of interest is the aorta, it is actually the very specific maximal diameter of the aorta. That is why we always ask you to remember that in our basic applications, your area of interest is white. This reminds you to be sure that you are looking for the outer echogenic walls of the aorta to be sure its maximal diameter is less than 3 centimeters. In this case, we see that it is. The diameter can be measured by calipers on screen or be estimated by the hash marks on the right-hand side of the screen. Incidentally, here is the IVC, and it appears relatively collapsed in this still image. Now this scan represents a normal aorta, but if you were to come across this image in a symptomatic patient, then this might be a real game changer. We still see the vertebral body and the acoustic shadow behind it, and the aorta is fairly evident. However, when we carefully look at the white outer echogenic walls, we clearly identify a more significant diameter. By counting the hash marks on the side of the screen, a quick estimate reveals that this aorta is upwards of 8 centimeters. Now let's move on to the actual hands-on technique in generating these images. As with all of our basic applications, this point-of-care aorta assessment can be done with either the curvilinear or the phased array probe. Either of these probes can be selected from the Triple Connect system on all of our Sonosite units. As you begin your training, you may find the curvilinear probe a bit easier to use. Many find the nature of this probe a bit easier to grasp probe technique, and the larger footprint of this probe may help in the assessment of the abdominal aorta by causing more displacement of bowel as you interrogate the abdomen. As you gain confidence, the phased array probe is equally suitable for this study, with only a few minor adjustments required to optimize scanning. Once the probe is selected, we can set its initial depth to 18 to 20 centimeters to be sure we are seeing deep enough into the abdominal cavity. As a reminder, the depth buttons are located here on the keyboard and will be shown here on the screen. For this assessment, the patient will be supine, and you'll be aiming to see the length of the abdominal aorta in transverse cross-sectioning from the xiphoid to its bifurcation, usually found around the level of the umbilicus. As we will see in the next video, the probe should be positioned at the level of the xiphoid process and oriented with the probe marker pointing towards the patient's right. The probe should always be perpendicular to the skin to maintain a true transverse plane of scanning of the abdomen. With respect to technique, it is easiest to hold the curvilinear probe with your thumb and index finger, allowing your remaining fingers to rest gently on the abdomen. Holding the probe perpendicular to the skin is key in obtaining maximal resolution in this exam. Here are several examples of less than ideal technique, most of which are uncomfortable and don't allow precise movement of the probe. These should be avoided. So let's have a look at a real-time scan of the aorta. Here you can see some gel has already been placed on the patient's abdomen, although as you first start out, you might consider using quite a bit more. This will allow you to improve the contact between probe and skin, minimizing interference from air. Here we can see the ultrasonographer palpates for the xiphoid process, places the probe in true transverse plane, and slowly sweeps down the length of the aorta towards its bifurcation. As we review the scanning technique, we can also now see a representative ultrasound clip showing the expected findings of this study on screen. As you begin scanning, you will quickly realize that it is impossible to avoid bowel gas on these studies. This is problematic, as air creates scatter artifact, sending the ultrasound waves in random directions, resulting in disorganized reflections back to the ultrasound probe. This precludes the generation of a crisp image in the far field, the area we are trying to interrogate. It is possible to improve your images by trying a few techniques to temporarily displace the interfering air. The first technique is to apply some firm tonic pressure with the probe and wait for the air to peristalse out of the way or for the bowel loops to be displaced away from the ultrasound beam. Once applied, be sure to be patient with that pressure. It can take several seconds before the air pockets begin to move and the desired image appears. If the aorta does appear, attempt to keep that pressure and continue the scan towards its bifurcation. If this technique is not working and is repeated without effect, try adding the second technique of asking the patient to inhale and exhale. Here, when the patient takes a breath in, you might catch a glimpse of the aorta. If not, asking the patient to exhale fully and follow their loosening abdominal muscles with firm pressure on your probe, you may get a glimpse of the aorta. Again, if successful, attempt to get to the bifurcation with good visualization before the patient takes their next breath. By combining these techniques, it is usually possible to salvage several scans which would otherwise be abandoned as indeterminate. The majority of aortas you will scan will bifurcate at or near the patient's umbilicus. The umbilicus is an air-filled structure, and as such, scatter may make your assessment difficult. We may also encounter foreign bodies such as piercings, as we demonstrate in this model patient. One option is to fill the umbilicus with gel to remove the majority of the air pocket, although to be honest, this is not a technique I use frequently. The second option is to orient your probe in such a way that you get a glimpse under the umbilicus from its lateral aspect, as is shown here in this clip. It is important to visualize your area of interest prior to performing this maneuver and keeping it in view at all times. This ensures that you are always following the right vessel as you change your plane of scanning. As you become more familiar with generating these images, it'll become apparent that it can be difficult to differentiate the aorta from the IVC. As we can see on the screen, both vessels are pulsatile, so this cannot be used as a distinguishing feature. As a reminder, the aorta should satisfy the following criteria. It should be immediately adjacent to the vertebral body, our sonographic landmark, and it should have a thick outer echogenic wall relative to its IVC counterpart. Additionally, the aorta will not collapse with compression, whereas the IVC will. This can be tested with the same technique we use to displace bowel gas. And finally, although rarely used, the IVC is susceptible to intrathoracic pressure variation, and as such it will vary with Valsalva and sniffing maneuvers. Here we see a real-time clip of a change in caliber of the IVC in response to a sniffing maneuver. Here, the negative intrathoracic pressure has resulted in collapse of the thin-walled IVC with no change in the thick-walled aortic diameter. A similar finding would be seen with external compression of these vessels. Differentiating between the two vessels is important, and with little practice is easy to do. The nice thing is that regardless of proper distinguishing between the two, any vessel at the level of our sonographic landmark that exceeds 3 centimeters in diameter is likely abnormal and merits further evaluation. We will touch on these sources of false positives in our next screencast in this series. Once you have identified your area of interest and performing your assessments, it is useful to know how to properly measure the distances in question. When you have found a desired location to measure the aorta, hit the freeze button and scroll back using the trackpad to the desired frame. This will be the one that you believe the aorta is maximal in its diameter. Using the caliper function, you place your markers on the outer walls of the aorta, and the measurement will appear here. During your initial training, we ask that you archive your scans of the aorta in QPath. Ideally, these scans will show the spine in the 6 o'clock position, the aorta centered somewhere around the middle of your screen, and ideally will also show a still image with your caliper measurements of its maximal diameter. It is possible that you archive 3 to 4 great images of an aorta, yet still call it indeterminate at the bedside. In this case, your text interpretation on screen should reflect this. So this concludes our introduction to point-of-care scanning techniques of the abdominal aorta. Be sure to review the next screencast in this series, where we will review the clinical applications, pearls, and pitfalls of assessment of the aorta. You can find all of these resources at WesternSono.ca.